The following podcast is part of a certified educational activity titled Personalizing Care for Patients with Prostate Cancer, Collaborative Strategies for Modern Integration of Systemic Therapy. Access the entire activity and complete the post-test at peerview.com/TRG860. Downloadable slides and practice aids are also available.
Good evening. I guess we should get started. Thank you for attending this meeting. It's entitled Personalizing Care for Patients with Prostate Cancer, Collaborative Strategies for Modern Integration of Systemic Therapies. And it's true that we now have quite many systemic therapy to play with all the patients in this disease, which is great news, as opposed to what we had some years or even decades ago. I'm Karim Fizazi, and joining me tonight are Professor Stephen Friedland, which actually lives and works almost next door in LA. Steve is a urologist. And to his right-hand side is Professor Matthew Smith, who doesn't work next door. You need to cross the country to meet him in Boston. And I'm a medical oncologist also. To meet me, not only you need to cross the country, but you need to do a little of swimming in the Atlantic Ocean because I work and live in France. So goals for tonight. Hopefully you will learn that clinical evidence and also real-world experience highlight the benefit of intensification of systemic treatment in various situations of prostate cancer. And all in all, we spoke about it earlier today at the Congress. It's getting more and more important to better understand in which patient we should consider intensification. Also, individualization will be important. Not all treatments are made equal, and of course, not all patients, not all cancers are made equal. So that's getting even more important. And also because these treatments have side effects and cost, it's becoming very important to better understand how to best handle them, make the right indications. And the best for that is clearly to use collaboration with a team. So with not further ado, let's dig into some data. And first, I'd like to show you and you probably know that again, we're not made equal on this planet. And this is also true when it comes to presentation, clinical presentation of prostate cancer. And I'm saying that because here in the US, only say 5%, maybe slightly more now, say 10% of the patients have established metastatic disease when they're diagnosed with prostate cancer. The vast majority of patients have localized disease. In Europe, depending on where you are, it ranges from 5 to up to 30% more in the east and in the north. Now, if you go to China and India, and I'm mentioning those countries for obvious epidemic reasons in terms of the size of the populations, approximately 60 to 70% of the patients who are diagnosed with prostate cancer do have metastasis at diagnosis. So truly showing you that we're not speaking about the same thing, depending on where we are when we speak about prostate cancer. You may think, okay, well, but here we're in the US, so let's concentrate on all our local situations. Fine. But now if you look at the death from the disease and you try to figure out what was the situation when the patient was diagnosed with his prostate cancer, before eventually dying from that, you will realize that more than half of the death from prostate cancer in Western countries appears to be related to situations of de novo metastatic disease, the other smaller half being upfront localized disease and then things turn bad. So again, metastatic upfront metastatic disease is a key situation that we need to better address if we want to save life, simply. Now, coming to an important point. This is your patient viewpoints. If you were asking your patient, after they have started their treatment, actually what opportunity would they foresee to improve preparation ahead of receiving their treatment? They would say the most important to me would have been to better understand possible side effects, because side effects count a lot to all our patients. And that sounds obvious, but again, it's important. In our talk, we keep speaking about efficacy, but for patients, safety is also really key. Also, having done more research on the various treatment options is important. And obviously, for localized cancer, this is key. We should not any longer tell all our patients, you got localized prostate cancer, your treatment is X. Because in many in situations of localized disease, actually it's X or Y or Z. And we should be honest about this and give the patients the opportunity to participate to the decision making when we can. And there are others. I'm not going to go into all the details for the sake of time, but again, we should better listen to all the patients. This takes me to shared decision making, which is truly an important thing, at least to my heart. You can actually go to the ZERO Prostate Cancer documents, and that's amongst others. But again, this can provide your patients, but also your staff or anyone you want more information regarding those. With us, I'd like to ask Steve to give his talk about high-risk patients with biochemical failures post-localized or local treatment. Steve, please.
Great. Thank you so much, Kareem. And it's great to be here with you, for those in the audience as well as virtually, to talk about what really has seen some remarkable changes in how we manage this in just the last couple of years. And I want to start with the patient. We're not going to get into all the details. We'll come back to that towards the end of my talk. But this is Robert. He's a 68-year-old cisgender white man who originally presented with localized disease, high risk, Gleason 8. PSA was only 8, so found early, but high risk disease. He underwent PSMA imaging, which was negative, and very appropriately undergoes radical prostatectomy. Could have equally chosen radiation, but he chose surgery. And they found a little bit of Gleason 3, so it's actually downgraded to 4+3. We actually see that not infrequently at the time of surgery. But he had a positive seminal vesicle invasion, which we know is a very poor prognostic sign. Nodes were negative, positive margins, and his initial PSA was less than 0.01. And I think some might make the argument he should have gotten adjuvant radiation because of the seminal vesicle, positive margins, clearly kind of bad disease. But I think we also have randomized trial data that we could watch him, which is what we had done. And the PSA unfortunately started to rise rapidly. Repeat PSMA imaging was negative, and then they went salvage radiation with 6 months of hormonal therapy. We heard today data whether he needed the hormonal therapy. We could, I think, debate with the PSA of 0.3. We didn't have molecular markers in terms of the tumor at that time, but he responded well, whether it's the radiation or the hormones, always hard to know. And interesting, and we'll come back to this in some of the discussion, is he had severe depression while on the hormonal therapy. And then after the 6 months and that wore off, that depression resolved. So again, we're going to come back to this case. But what we do know is that in patients that have biochemical recurrence, it is a very heterogeneous disease. Just like initial prostate cancer, PSA of 100 with METs is very different than a PSA of 5 and a Gleason 6. And yet they're both prostate cancer. Same with biochemical recurrence. You might think you failed surgery, radiation, it's all going to be aggressive. That's actually not the case. And so this was a study looking at patients who had failed radical prostatectomy. The PSA had come back, and they were followed over time with very little secondary treatments until metastatic disease. And then they got hormones. It's a historical paper. And what you can see is if you're doubling time, the time it takes that PSA to go from 1 to 2 to 4 is less than 3 months. The median survival of those patients is about 6 years. If your doubling time is 3 to 9 months, median survival is about 10 years. And if it's greater than 9 months, at 15 years, you have 75% survival or better. So you really do see this separation at the 9 months of aggressive recurrence versus less aggressive recurrence. And tables were developed based upon these data that really can take into account numerous factors, not just the doubling time, but the Gleason score, 8 or higher being particularly aggressive, less than 8 being less aggressive. Did you recur late? Tends to be less aggressive disease. And what's interesting is you put this together, and if we look on the right side here, at 15 years, we can separate out survival of 94% prostate cancer survival with essentially no secondary treatment versus less than 1%. It's really quite powerful. And this is in the era of pre-genomic analysis, pre-PSMA PET, but even just based upon standard clinical variables, we really can identify those patients that are going to be in trouble. And so the thing to do is now, when can we do for these patients? And particularly those with a short doubling time, we do have some salvage therapy options, salvage radiation, which works in some patients. It's not as used as often as it should be, but unfortunately, it doesn't always cure the cancer. And particularly in these short doubling times, it often doesn't cure the cancer. And so they go on to ultimately need systemic therapy. And while we're still debating when to start that hormonal therapy, we at least now have some answers as to how to deliver that hormonal therapy. And that's based upon the EMBARK study. And so this is a global phase 3 randomized trial of people in that short PSA doubling time, that high risk biochemical recurrence, no evidence of metastatic disease by conventional imaging. EMBARK started in the pre-PSMA era. They had to have PSAs high enough that you could calculate an accurate doubling time, be a little bit closer to metastatic disease. And basically, they either had to have surgery or radiation. And if they had surgery, they couldn't be a candidate for further salvage radiation. Not everyone had it, but they couldn't be a candidate per the treating physician. And they were randomized in the middle to what we've done for decades for these patients, which is hormonal therapy, ADT. And we'll see in the later stages, enzalutamide, a drug that blocks androgen receptor, has really revolutionized care for metastatic disease, castration resistant. And so the question is, could we add it even at this non-metastatic space based upon conventional imaging and improve outcomes? And then for the first time ever in a phase 3 trial, we actually said, wow, this enzalutamide looks pretty good. Maybe we don't even need ADT anymore. So can we do an ADT sparing approach? Patients were treated for 9 months. If PSA dropped to less than 0.2, treatment was stopped. PSA was followed. And when it hit pre-specified thresholds, the patients would go back onto their originally assigned treatment. And the primary outcome was metastasis or death, also known as metastasis-free survival, which has been shown to be a surrogate of overall survival in this disease space. And what we see here is, in terms of that primary outcome, metastasis-free survival, you see there on the left, what we see is enzalutamide plus ADT, really dramatic delays in metastasis or death with a hazard ratio of 0.42, so a 58% delay in the development of metastasis or death, essentially keeping our patients alive without metastasis. That's where we want our patients to be, keeps them alive there much longer. And even on the right, we see that enzalutamide by itself actually improves upon ADT, not quite as impressively as the combination, but nonetheless, with a hazard ratio of 0.63, 37% improvement in delaying metastasis or death. And ultimately, this led to the FDA approval of enzalutamide with or without ADT for these high-risk biochemical recurrent patients just over 2 years ago. More recently, just a few months ago now, we presented updated overall survival data, which had been immature on the initial presentation. And what you see here is enzalutamide plus ADT reduced the risk of death by over 40% relative to ADT alone. And based upon the hazard ratio, this is the greatest survival benefit we have ever seen in a global phase 3 trial. Really, really impressive when we take drugs that work, if we find a patient population that's really at high risk of progressing, and treat early. Unfortunately, we did not see a statistically significant survival benefit with the monotherapy. While numerically it favored improved survival with monotherapy, with a 17% reduction in the risk of death, this did not reach statistical significance. So we've done some analyses of the EMBARK data after the fact, and what you see on the left is that by and large the efficacy of the drugs, based upon whether you are younger, age less than 70, that was our cutoff, that was a median age of patients on the trial. We can debate whether that's younger or not, that we actually saw versus those that were older, 70 or older, we saw no difference in the efficacy of the drugs. We did see a little bit higher adverse event rate in the older patient population, but the efficacy of the drugs were the same. What we presented here is some very, I think, intriguing hypothesis-generating data. We had some debates as to what to call this, but these were patients here who got the treatment suspension, and the PSA and their testosterone came back to 250 nanograms per mil, so normal, but yet their PSA stayed less than 0.2. So whether you call them remissions, whether you call them cures as hypothesis generating, trying to be provocative, nonetheless, at 3 years, you see a portion of patients, they are small, but in the enzalutamide combination, there's about 4% of patients. So 1 out of 25 patients, we can say based upon 9 months of treatment, 3 years later, you will have a normal testosterone and a quote-unquote undetectable PSA. So very, very thought-provoking in terms of, are we getting sustainable remissions in this patient population? Obviously, all drugs have side effects. Enzalutamide is certainly not immune to that. Again, we saw tremendous overall survival benefits, but we do see a little bit more side effects. And, basically relative to ADT alone in the middle, enzalutamide combination increased the risk of pretty much every side effect we looked at, which makes sense. It's better ADT, so you should see more ADT side effects. If you don't see more ADT side effects with a drug, you start to wonder how well is it really working. With the enzalutamide monotherapy, it's very intriguing. You're not castrate, so you have plenty of testosterone. Testosterone actually doubles, gets aromatized and converted to estrogen. And what that estrogen will do is, one is go to the brain, and so you have plenty of hormones. You don't need to have hot flashes because you still have plenty of estrogen. So hot flash is much lower, but it can also go to the breasts. And we see here gynecomastia, 45%, breast tenderness, 14%. So it was not part of the trial, but now we are recommending either breast irradiation prior to starting monotherapy and or tamoxifen, with doses kind of all over the place, 10 to 20 milligrams, I've heard from daily to as low as weekly, to really try to prevent those side effects. And again, you do get side effects. So things that we can do in terms of fatigue, muscle loss, weight gain, side effects of all ADT and RPs, diet, make sure the patients are getting great exercise, getting good sleep, particularly resistance training exercise, bone loss, again, class effect with ADT as well, calcium, vitamin D, bone protected agents, little less clear in the castrate sensitive space, their role, but certainly if patients have osteoporosis, again, exercise, hot flashes, some lifestyle changes, cognitive behavioral therapy. There was just a randomized trial published in JCO that oxybutynin could actually reduce hot flashes. I was surprised, but it was a positive study. And again, we talked about management for gynecomastia. So there are some other studies that we're still waiting to see in this space. The ARISTEP is another trial, similar in some respects to EMBARK, in that selecting high-risk biochemical recurrence. The definition here, though, is PSA doubling time less than 12 months, not the 9 months, allowing lower PSA levels. But the caveat here is everyone has a PSMA positive scan. Again, it was not available at the time EMBARK was done, and randomized to darolutamide plus ADT or placebo plus ADT. So we don't have that RP monotherapy. Treatment for 24 months, and then stop treatment. The primary outcome of radiographic regression-free survival by PSMA imaging. So some similarities, some I think conceptual similarities, some differences in study design though, and we're still eagerly awaiting these results. But one of the things, bringing in some real-world evidence that we see is what we're finding is on the left side here. This is basically, we went through some charts, or actually asked physicians to go through their own charts. And we basically said, what is the patient's doubling time? They all have high-risk biochemical recurrence. And amazingly, often the physician would say, actually the majority of the time is, we don't know. We actually don't know what the patient's doubling time is. I can't tell you in a case report form. And so what we found is that physicians that knew the patient's doubling time, PSA doubling time known, this is the likelihood of them getting secondary treatment. They were getting treated much more aggressively. Whereas when the physician couldn't even tell us the doubling time, they actually were getting treated much slower. And these were all high risk that you could make an argument should be getting pretty aggressive early secondary treatment. So just going to the importance of knowing these data. And then for the ones where they told us that they told us that patient's doubling time is 6 months, 9 months, whatever. We actually had the real PSA data. So we could go behind their back, so to speak, and calculate it. And what we actually found is that the physician-reported doubling times were often much longer than the real one. Longer doubling time means slower disease. So the physicians were essentially underestimating how aggressive the disease was. So a lot of real-world practicality, even though we now have trial data, we have guidelines based upon doubling time, doing this in the real world remains challenging. So where is the future going with this? This is recently reported out at ESMO. This is Enzarad. This is enzalutamide plus ADT for radiation patients. And so this was high risk, some very high risk, undergoing radiation therapy. And what you see here is if you had positive nodes, adding enzalutamide at the hazard ratio of 0.43 and 0.46 for overall survival improved outcomes. But the number of patients that had positive nodes were pretty low in the study. And for those that were node negative, you saw no benefit of enzalutamide. It's the same drug that we just showed had a 40% survival benefit. And what ultimately came out, and this is similar to what Karim presented earlier, is these patients here actually are doing pretty well with the current standard of care. And this was the data that Karim just presented earlier. Great presentation, by the way. And basically, it's a similar question. Can we take high-risk radiation patients and improve their outcome? In this case, using cabazitaxel chemotherapy. And the short answer is no. And part of the reason is the patients are actually doing pretty well. So it's hard to improve when the patients are doing well. it's hard to improve upon that. There are other ongoing trials we are actively awaiting for: Proteus, Atlas, Dazzle, HiCap, and will help define what is the role of these therapies for early stage disease. And, again, things have changed. We're using PSMA imaging. We have some negative imaging. We have positives seen on the CT component. And this is really where I think a lot of us are struggling. The oligometastatic, not seen on the CT. How do we treat those patients? How do we bring in salvage radiation with our systemic therapies? And I'm not sure we necessarily have the answers at this stage. So let's come back to our patient. Again, he had the depression, and after his radiation, his PSA starts to rise. PSA is now 1.5 with a 3-month doubling time. Clearly, PSMA imaging repeat is negative. We're getting into EMBARK territory, no more salvage radiation options for him. Discuss pros and cons. He was not sexually active, which would have been one of the real selling points for monotherapy. And so basically he was, a little bit nervous of ADT with the depression, but his thing is, I want to get off treatment. I don't want any treatment, but if I do, I want the greatest chance I'm going to get off that treatment in 9 months. And based upon that, he ultimately chose the combination therapy. And he had some fatigue early on. We decreased the dose. And interesting, he was actually diagnosed with pneumonia. We treated the pneumonia, his fatigue got better. It wasn't necessarily enzalutamide related. Just reminds there's many reasons patients can get fatigue, not just enzalutamide. He did not get any depression. Interestingly, he said the depression was when he was told his cancer was back, and it was the beginning of the pandemic. That it probably wasn't actually the ADT. Again, there are many reasons patients can have side effects. That's not always the treatment. And so the question is, he's now back on treatment. His PSA is responding nicely. And so the question is, do we stop the treatment? So he actually stopped the treatment, and his PSA went back up. I don't have it on here. And then we put him back on treatment, as you would on the protocol. And now it's been another 9 months. Should we stop it again? Where do we go? How do we manage the AEs? So Kareem, I'd love to hear your thoughts. This is not how the study was done, but can we stop it again?
No, I think it's a key question, and I think just for the audience to better understand, in EMBARK indeed, patients received 9 months of treatment, and as Steve explained, if they had a PSA down to 0, they could stop on drug and restart when the PSA would rise again. But then, when you would restart as a continuous treatment, say with a combo, for
Correct.
example.
I'm stay on it for life,
Exactly.
essentially.
And I agree with you, because especially for this gentleman, and especially if the depression or at least the fatigue would be drug-related, then you would be really tempted to go for an intermittent treatment. And historically in these men, when I was treating them with ADT, I was using, and probably still now, intermittent ADT. We have, for example, the Canadian large phase 3 trial comparing intermittent versus continuous in the setting. And actually the data supports similar efficacy with, of course, lower toxicity for the intermittent arm. So it would be indeed tempting to do the exact same thing with this BiFi therapy. But again, this is not what was done in EMBARK. And I like also to see evidence-based. So I would be on the fence, to be honest. What about you?
Well, I know what I did, so I'd love to hear Matthew's thoughts, and then I can tell you what we did.
Yeah, the world moves on too. So he's PSMA PET negative, so he's better than the average patient that enrolled in EMBARK, because we don't know, right? Many of those we expect most of them would have been PSMA PET positive, had more disease. And I think the data you referred to from ADT alone, which extends also to metastatic disease, right? I think it's appropriate for highly selected patients. I think you can make a good case to do that here. I accept that, you might be leaving something on the table. That's what I tell patients. You may lose a little bit of the benefit of treatment by interrupting therapy, but I would speculate that it's probably a very small difference if you were to do that trial.
Yeah. And that's what we did. We stopped it. And, it's interesting when you look at EMBARK, the median time to testosterone recovery is about 6-8 months, somewhere around there. You get about 18 months off treatment. So about 6 to 8 months to get your testosterone back, and then about 10 months of normal testosterone.
One thing, sorry to interrupt, I don't think you told us though how long he was off treatment. So that matters a lot to me.
Correct, and that's what I say. It was shorter than I would like,
Yeah.
but his testosterone recovered pretty quickly. So he got a good about 10 months of normal testosterone, which is kind of on average, but his testosterone recovered much quicker. So it was probably about a year or so that he got off. But we ultimately did. I mean, we had a lot of these discussions and things, and all right, this is the trial. The results are pretty good. Do we want to risk things or not? And
Share decision making. Yeah. And I was thinking, we saw also when you presented the updated data at ESMO, we saw the other randomized trials with apalutamide, which actually was kind of negative in the same setting, but with actually an intermittent scenario. And I was thinking whether this actually made part of the difference between the two.
yeah, so I mean, so it's interesting. So what Kareem was talking about is there was another trial done with apalutamide that it had some similarities again. But what they did is they took the same doubling time, less than 9 months, 52 weeks, not 9 months. I'm not sure that makes a big difference. Treated with apalutamide and then stopped. And there was no pre-specified time to go back on therapy. And if you went back on therapy, at that point you were off the study, so you would go back on ADT. And so I think that's the difference, not that they had a break, because Embark had a break, it's that they didn't have that opportunity to go back on doublet. And I remember I got the question, ESMO, do you think it's the first 9 months or the long-term combination? And we saw the data. There's a few, if the 9 months is good enough, but it's really, if you're going back on, you got to go back on the original treatment.
I just saw that we just received several questions, so let's take them briefly if we can. And I was actually about to ask you the first one. Nowadays that we would probably scan these patients with PSMA PET, and very likely PSMA PET would pop up with 1 or 2 mets. Would you still use the Embark regimen? Would you integrate stereotactic radiation on top of it? What would be typically your practice?
So short answer is both, all of the above. So yes, systemic therapy for 9 months. Yes, radiate those patients and hopefully get a much longer treatment suspension.
Second question is about concomitant cardiovascular disease / risk factors. Would you handle these patients the same, or would you be less aggressive in your approach if they are really at risk?
Yeah, I mean, if you had really bad ischemic heart disease, you don't get on any of these enzalutamide or apalutamide or other trials. But some heart history would have been typical of 70-year-old prostate cancer patients after these treatments. And the overall survival benefit is phenomenal. So absolutely, I would put them on the regimen. And we actually had him, just because I was one of the first patients post the trial that I wanted to do, I had him see a cardiologist in advance.
And last question was about single agent enzalutamide. What about continuing this treatment? Do you think this would make sense?
I think so. There's a million thoughts I have about that. But I do think there's probably value in maintaining enzalutamide monotherapy, not doing the treatment suspension, and hopefully maximizing efficacy based on a lot of data we don't have time to get into.
Thank you so much. Let's now invite Dr. Smith giving a talk about the situation for metastatic hormone-sensitive disease.
Thank you. Good evening. It's nice to be here and share the stage with my colleagues and friends. So I'm going to begin by presenting a case, very similar form to what Steve had done earlier. This is Charles. He's a 70-year-old retired accountant. He enjoys gardening and travel with his family. He's diagnosed with de novo metastatic prostate cancer after presenting with recent onset of lower urinary tract symptoms. That prompts measurement of his PSA, which is 57. Prostate MRI reported 2.4 centimeter PIRADS 5 lesion and pelvic bone metastases. Subsequent PSMA PET CT reported PSMA avid pelvic and retroperitoneal nodes and extensive PSMA avid bone metastases. His history is notable for hypertension that is well controlled on lisinopril, hypercholesterolemia on a statin, and osteoarthritis, for which he takes over-the-counter NSAIDs. And we'll come back to that case at the end. So think about that case as I now present the data that we have for optimal management of MHSPC, also known as MCSPC. It's been quite a decade, and that's sort of summarized here. This represents most of, or many of, the trials that have transformed clinical practice in MCSPC. About a decade ago, the first docetaxel treatment intensification trials were reported, showing an overall survival benefit, and then a subsequent raft of trials looking at doublet therapy with androgen receptor pathway inhibitors, abiraterone, enzalutamide, apalutamide, and then following the success of those trials, a couple of trials that looked at so-called triplet therapy with ADT ARPI in combination with docetaxel. So I'm going to run through some of this data, but it's really worth in some ways celebrating how much the treatment landscape has changed. It's also important to note that real-world data continues to show that a surprising high minority of patients continue to receive ADT alone, despite compelling evidence for overall survival benefits with treatment intensification. So here's some of the representative trials, and here we're looking at overall survival. You can see the curves separate early, and they remain separated throughout the course of these trials. That spanned intensification by addition of docetaxel to ADT, apalutamide, abiraterone, and enzalutamide. If you focus on the three ARPI studies, it's notable how consistent these observations are. The hazard ratios are nearly identical at 0.65 or 0.66. And this carries through with other trials done in the similar disease space with the ARPI. So really remarkable, consistent, and clinically significant improvements in overall survival by treatment intensification with either docetaxel or an ARPI. Now, this, of course, raised the obvious question, which is, well, which one? Do you give an ARPI or docetaxel? There has not been a direct comparison of these, but there's been a contemporaneous comparison with the STAMPEDE trial that compared arms C and arms G for patients who were randomized at the same time to either standard of care plus minus docetaxel or standard of care plus minus abiraterone. So they weren't a head-to-head randomization, but they were enrolled in those two different arms at the same time. So it does allow for a contemporaneous comparison, which is, to say it concisely, the next best thing to a randomized controlled trial. And here's the data from this comparison. You can see on the right that there's no significant difference in overall survival between intensification with docetaxel versus abiraterone acetate. But for most of the intermediate endpoints, there's a benefit favoring abiraterone over docetaxel, and that includes failure-free survival, progression-free survival, and metastatic progression-free survival. There's a couple potential explanations for this difference in the intermediate endpoints. It could just be flat-out abiraterone is better than docetaxel. I would like to believe that. The other point is that abiraterone is, as you know, is administered continuously until progression. So these events would have occurred during abiraterone treatment. Docetaxel, in contrast, is given for 6 cycles and then stopped. So these events may have occurred when the patient was off of their treatment intensification. But I think patients and physicians really vote pretty clearly with this. Given the choice between the two, nearly all patients would prefer an androgen receptor pathway inhibitor. It did leave the question, though, of whether there's a role to look at triplet therapy, meaning combination of ADT, docetaxel, and an ARPI. So this is the ARASEND study. It was designed soon after docetaxel was demonstrated to improve survival, but before we had any data for the role of ARPIs in treatment intensification. And knowing that, we chose to use ADT docetaxel as the backbone, meaning if you're going to build on success, you have to choose the winning arm of the previous trials. And so the control group was ADT docetaxel plus placebo, and the intervention arm was ADT docetaxel and darolutamide. This study enrolled the newly diagnosed metastatic patients, stratified by extent of disease, randomized 1-to-1 to those two arms. We really felt if you're going to move the needle in this disease, you had to improve overall survival. So the primary endpoint was overall survival. Here's the data. Randomized trials are hard to do, but easy to understand. You can see early separation of the curves, and it remains separated throughout the course of the trial. Hazard ratio of 0.68, nearly exactly the same as when the treatment effect you saw for ARPI plus ADT in a similar patient population. And based on these robust overall survival benefit, darolutamide was approved in MCSPC in combination with docetaxel in August of 2022. So what about quality of survival in the ARASENS study? This is data presented at this meeting, a so-called Q-twist method of analysis. There's lots of words and figures there, but basically the idea is to try to understand the impact of treatment on quality of life. So what you want is time without symptoms or side effects of treatment, right? And so this is represented really in a very nice way, I think, here graphically. If you look at the green bar, like the green part of the Kaplan-Meier curve there, you can see that that is much larger for darolutamide compared to placebo. So said a different way, the time without symptoms of the cancer or side effects of treatment is greater in patients who receive darolutamide versus placebo. And that's really true throughout the course of the period of observation. So supporting not only is there an overall survival benefit, but that comes actually with what appears to be a benefit in quality of life. Now, the question that ARASENS did not answer is whether darolutamide improved outcomes as a doublet therapy. Now, there'd be no reason to think that it wouldn't, because it's very similar based on other data from the other androgen receptor pathway inhibitors. But nonetheless, there was a need to demonstrate that in a randomized controlled trial. And this sort of led to ARANOTE, which is darolutamide without chemotherapy in patients receiving ADT for metastatic prostate cancer. Here, a somewhat smaller trial designed really to proof of principle, and the endpoint was radiographic progression-free survival. And you see a large effect on rPFS with the hazard ratio of 0.54. And that was sufficient for the FDA to expand the label of darolutamide as doublet therapy in June of 2025. There have been a variety of post hoc analyses of ARANOTE. This is one presented nicely by Fred Saad at this meeting. And what was looked at in this poster was whether the benefit on rPFS was maintained according to patients' baseline comorbidities and medications. You might wonder whether if a patient is frailer or takes certain other medications, that they might have a decrease in the treatment effect, in part presumably due to compliance or ability to tolerate therapy. And the take-home message here is that there's consistent benefit, as you can see in the forest plot, across all these various subgroups according to baseline comorbidities and/or concomitant medications. The other extremely important trial in this of triplet therapy in MCSPC was the PEACE-1 trial led by my colleague Karim Fizazi. This is a 4-armed trial, standard of care plus abiraterone, standard of care plus prostate radiation therapy, or standard of care plus prostate radiation and abiraterone. So why triplet therapy? Well, because as it was originally designed, patients could receive docetaxel at the discretion of the treating physician. And then somewhere, I think about halfway through the trial, the study was changed to require docetaxel. And so this then allows the ability to look at patients who did or did not receive docetaxel and ask the triplet therapy question. Here you see a nice effect on overall survival, standard of care plus abiraterone acetate in the overall population, hazard ratio 0.82, statistically significant. And then on the right panel is the docetaxel subgroup showing an even greater effect with the hazard ratio of 0.75, and that too reached statistical significance. So responders do better than non-responders. That's sort of a general principle in oncology, and it's certainly true in prostate cancer. And this has been nicely demonstrated in a series of studies that have looked at PSA nadir in patients receiving doublet therapy for MCS-PC. And here, in these various studies shown here, they were looking at patients who achieved a PSA nadir of less than 0.2. And you can see this early separation of the curves, big difference between the various subgroups, again, reinforcing the end point of an undetectable PSA on treatment confers a better overall outcome. Again, consistent with general principles of oncology, which is that responders do better than non-responders, but it does open the question of another way you could use this kind of information to design a next generation of trials that look at patients with suboptimal response to standard treatment. Treatment, as Steve said, does come at a cost. All drugs have side effects, and certainly true of the ARPIs. So this is sort of a partial summary of the comparative issues between at least the androgen receptor binding agents, apalutamide, darolutamide, and enzalutamide. They come in different dosages. They have the same route of administration, but they do have some differences in their adverse events. Apalutamide has more rash. Apalutamide and enzalutamide cross the blood-brain barrier to a greater extent than darolutamide and come with risks for CNS side effects, including greater risks for falls. Early studies of enzalutamide reported very low rates of seizures, and then the drugs have differences in their potential drug-drug interactions. All the drugs have issues related to fatigue, hypertension, and increase in hot flashes. So a couple of presentations at this meeting looked at safety and the real-world experience. Neil Shore presented data. There was a matching adjusted indirect comparison in MCS-PC of patients receiving darolutamide in combination with ADT compared to other ARPIs with ADT, and found that darolutamide had a preferable or better safety profile, at least as it related to certain side effects, including fatigue, compared to enzalutamide, and less rash compared to apalutamide. Alicia Morgans presented real-world outcomes associated with enzalutamide versus apalutamide in MCS-PC, and they concluded that there was basically similar effectiveness of enzalutamide and apalutamide in this setting. I guess that would fit with our understanding of the two drugs as they're structurally very similar. In other studies, randomized controlled trials have reported remarkably similar outcomes. All right, so back to my patient Charles, 7-year-old man with de novo metastatic prostate cancer, metastases involving retroperitoneal nodes and extensive bone metastases by PSMA PET-CT. He has some sort of typical comorbidities for men in his age group: hypertension, hypercholesterolemia, and osteoarthritis. After discussing his diagnosis with him, it was clear to me he had a good understanding of his prognosis, his cancer diagnosis, and his options for treatment. And it's very common. He kind of said, Doc, I want to live as long as possible, but I also want to maintain my quality of life. And I think more than most, he understood that there are trade-offs there. It's not you choose quality of life or length of life. There are trade-offs or considerations of that. And so the question, kind of classic question, contemporary question becomes, what do you recommend for systemic treatment in this patient? Is it doublet with ADT ARPI, or is it triplet therapy including docetaxel? Is there other information that you might consider in trying to make that decision? So what do you think, Kareem? How would you manage a patient like this?
Yeah, well, first, I agree with you. Those things need clearly to be discussed with patients. We need to take time explaining them the pros and cons, the current knowledge, and what we know, what we don't know. And here, for example, you clearly showed us that 3 drugs are better than 2 when the comparator is a hormonal chemotherapy control arm. What we don't really know is whether 3 drugs are better than 2 when it's a hormonal therapy. And we don't know because at this time this was not standard of care when we set a RAS and PIS1. So those are the things we need to discuss very clearly with the patients. I would say that Still, number one, the triplet data show probably the longest overall survival ever seen in patients with de novo, especially high volume disease. And de novo metastatic disease, as I said before, is not a good thing to have, as opposed to metastasis after relapse, after failure of local treatment. And actually, with a triplet, we really see quite long-term survivors. We actually should see soon, or hopefully soon, the updated PIS1 data with long follow-up, and it's quite good, I have to say. So it's my bias, but I would be more in favor of a triplet. Again, recognizing the pros and cons, and for somehow the absence of evidence versus hormonal therapy. At West Congress, actually, earlier today, I saw several indirect comparisons or real-life comparisons of triplet versus doublet, hormonal therapy, and every time the triplet was better. Again, not randomized, they might be biased, but I think this is also reassuring.
In some ways, that's surprising, right? Because the patients who get triplet therapy in our practice are the patients typically we have reasons to believe have particularly poor prognosis, and some of those are visible and some of those are invisible things, right, in a real world data analysis. So that is really quite compelling.
Matthew, one question on this patient here. You note extensive PSMA-avid bone metastasis. And we know in sub-analysis from Charted, just chemo alone, we saw in high-volume disease, impressive results. Low-volume disease, we saw no benefit to adding chemo. So I always wonder, for these PSMA-avid bone metastasis, did you also see them on the CT component of this? Is this just PSMA positive disease? Is this conventional imaging high volume, low volume? Because for me, that would go into the decision of the triplet versus doublet.
Great question, Steve. And so this was visible on his prostate MRI. They did bone metastases, and it was visible on the CT component. Although I will say, radiologists get really good when they see a positive PSMA PET CT to call the CT
Find something there.
It's a lot easier, right, if you get the nuclear medicine part of the scan.
So maybe just for clarity, if I may add, in Charted, actually, this was a mix of de novo patients and relapses. And actually, the absence of benefit of the Taxol chemotherapy was mostly related to low volume relapses. And this has been clarified in the meta-analysis of all existing trials, the Taxol yes or no. No benefit for patients with relapsed low volume, but actually for those patients with de novo disease, regardless of whether they have high volume or low volume, they tend to benefit from the Taxol chemo, which I think is important to remember.
So practically speaking, I agree with what Karim said. Practically speaking, I don't find like bone scan positivity or number of metastases to be sufficiently compelling that I would go back and do a bone scan to know how he would qualify. So in this patient, I don't know, and I chose that because this is how we practice now outside of a clinical trial context. But I would speculate that if he had a technetium bone scan, he would probably be high volume.
I mean, if it's seen on the MRI, that's conventional imaging.
Yeah. Yep. Are there other things that sway your opinion about these decisions, Karim? Like
maybe
ctDNA analyses?
Yeah, I was about to ask you a question about the recent data about biomarkers that may finally help us for decision making with regards to whether we should use the Taxol yes or no. What do you think about the data?
Which data are you referring to?
Decipher data.
Yeah, the Stampede data. I think, are provocating. What do you think?
No, I think that is beautiful data. It hasn't been validated in a prospective study, and it hasn't been evaluated in triplet therapy. To the best of my knowledge, it's doublet. That said, it's available, right? The other thing, there's other data that make maybe a similar case. I don't think it's quite as robust with tumor marker loss. The difference is we get tumor marker loss when we just do ctDNA analysis, which I routinely do in patients with de novo metastatic disease for a variety of reasons, not primarily to ask that question, but you get it in the course of doing it. Decipher is yet a different test to do, but I could see how that could be useful, particularly in a patient who you're on the fence about.
How often are you finding with patients like this where it's, the data are not, as you noted, robust for triplet versus a doublet with RP? You're going through, you're trying to be transparent to the data for the patient, and they're just like, they hear the word chemo and they just stop listening and they're like, nope, not going to do it.
Yeah, we get that. And I take the long view, like, as we're in this together, so we got to like understand what you mean by that. I try to understand their concerns about it, what the basis for their reluctance to receive chemotherapy. Sometimes it's very sound and reason. They've read about it specifically. Other times it's just a general conception about chemotherapy. The classic being, my aunt was fine until she went into the hospital and got chemotherapy. Cancer was the problem, not necessarily the treatment. So there's a lot of that. And the way I think about it too is, for a patient like this, it's like chemotherapy now or somewhat later. Like, so if the patient's out, like they really like, I will never receive chemo. I refuse to receive chemotherapy. At first I want to understand that, because they probably will when they have big trouble later. That's been my experience. But for a patient like this, I think it's really, the conversation isn't like chemotherapy now versus never. It's like chemotherapy now, where you're going to get in a year or two when you progress, which would be the, kind of expected result in many such patients. Not all, but many such patients.
I would really agree. And actually, I've almost stopped speaking about chemotherapy. I speak about docetaxel, what it is, what are the side effects, not the idea of a terrible chemotherapy the old grandma had for another cancer, because we just don't speak about the same thing. And if patients are reluctant, often I tend to tell them, you know what, if you're okay, we start with one cycle. And then I'll see you again in 3 weeks' time, and you'll make the decision. If it was just too hard, we will stop, fine. But if in your own experience you're comfortable continuing, then potentially it may help you.
I agree with that approach, and I take a similar approach. In very few patients then stop before they get their 6 cycles. It does happen, but
I agree. Oh, I think we have a couple of questions coming. What else is involved with managing the patients on triplet versus doublet? Who all do you get help from? What are patients' preferences? Right. So who all do you get help from about managing a patient on triplet versus doublet? What are patients' preferences?
Yeah, so I mean, there is a certain reluctance about receiving chemotherapy. I think, to Kareem's point, really important patient education about what that means and what a decision like that means to them. And they also have the ability to, like any other treatment, discontinue early if they find it too difficult. We, of course, take a team approach. It's not just me, it's the entire team of providers, nurse practitioners, others involved in their care that are instrumental in helping doing patient education around treatment and helping manage side effects.
So, second question, how does the difference in RPs crossing the blood-brain barrier impact outcomes therapy choice? Is that important for you for decision making?
Yeah, I think it is. Darolutamide was intentionally designed not to cross the blood-brain barrier, and I think generally, like I'll even say this with Steve on the podium, that is seen as the best in class for safety. I think the drugs are otherwise interchangeable for efficacy. You could argue about the differences in data from randomized controlled trials, but where we have similar data or similar patient populations, the data is far more similar than different for efficacy. I view darolutamide as best in class for safety, not only because it doesn't cross the blood-brain barrier and has less or no risk for falls than the other 2 ARPIs of the same class, but it also has fewer drug-drug interactions, and there's lots of patients where that can be an issue.
Let me finally ask you one question regarding Charles, maybe to the 2 of you. Let's assume he's getting the triplet therapy. He's done with his docetaxel. We're 6 months now. He's doing much better. PSA goes down dramatically. And he carries on with, say, darolutamide, for example, or the one you like. Would you consider adding local treatment with radiation therapy to his prostate?
Not in him, just because he had what we'll call higher volume disease. Where I do triplet therapy and prostate radiation are guys, younger, healthier men who I perceive as having a very high cancer, who have a poor cancer-specific mortality, despite not having a lot of metastatic disease. They just have, Gleason 9 or 10, big primary tumor, rapid onset of disease. So those are the rare patients where I'll do triplet therapy and prostate radiation. Patient like this, I would say generally no.
I think, the strongest data, Stampede, are certainly low volume piece showed in terms of delayed symptoms, other things. There is a SWOG trial going on for people exactly like Charles who get systemic therapy and have a very good response, then randomized to local therapy or not. So I would say it's if he responds really well, it's something I would probably discuss with him, but ultimately with the lack of data, and it would be his choice.
All right. Thank you. All right, let's move to metastatic castration-resistant disease now. I'll try to speak about precision medicine approaches. I think we now have important data from biomarkers, but also from drugs, making precision medicine a reality. So what do we have? First, we have taxanes, first drugs to show overall survival benefit in CRPC, the Taxel, and then 6 years later, the cabazitaxel, radium-223. We have also some questions around bone health considerations using denosumab and azelaic acid, lutetium PSMA more recently, PARP inhibitors, questioning us as to whether we should use genomic testing more frequently, and whether also we should combine PARP inhibitors with other drugs. Let's briefly review at least part of the data for the sake of time. So, radium-223, we know for, probably almost 15 years now, that radium-223 improves overall survival in men who have exhausted ADT, and for some of them, the Taxel. You can see the two Kaplan-Meier curves, but this was before the time of the AR pathway inhibitors that radium was approved in this indication. So that's a first. Then we had a second generation trial trying to combine AR pathway inhibitors with radium-223. The first one was ERA-223, which was led by Professor Smith. And actually, this was randomizing abiraterone plus or minus radium for these patients with CRPC and bone disease. And a surprise in the trial was when it was analyzed, was to discover that more patients in the combination arm would develop fractures, mostly osteoporotic fractures. And actually, the median time to fracture was approximately 32 months. And that was a significant difference, not supporting clearly the combination of abiraterone and radium-223. So at that time, another trial, second trial, was asking the same question, but this time with enzalutamide, with a design of enzalutamide plus or minus radium-223. And actually, because the trial was ongoing, all the colleagues at EORTC had probably two options. Option one, stop the trial just to avoid reporting the same data, the fracture data that were observed with abiraterone. Option two, knowing that this was mostly osteoporotic fracture, try to fix the osteoporotic problem and potentially some others using systematic denosumab or azelaic acid in the next to come patients in the trial. And they actually chose this second option, which was an amendment. What happened? This data, this figure shows you data before and after the amendment. Before the amendment, you will see the black curves, which is that of enzalutamide and radium, which was associated with approximately half of the patients developing at least one fracture by 2 years' time. So quite bad. Enzalutamide alone, again without a bone protecting agents, about 25% by 2 years' time. No good. Now, you will see in red and in bluish the same treatments, but this time with denosumab or hyaluronic acid protection. Almost zero fracture incidence with the same treatments. Bone protection does work. So this is clear demonstration that those agents are needed. And then, because the trial was amended early in its course, the final outcome is a good one, is a positive one, as you can see to the left-hand side by the primary endpoint of rPFS, the combination of enzalutamide plus radium does a better job as compared to enzalutamide control, and overall survival was also superior, even if at that time they could not formally claim victory, because this was an interim analysis, but still you can see the nice shape of the overall survival curves. Today we just saw at the oral presentation earlier this morning, Dr. Gallardo presenting us the updated overall survival data from the trial, and actually it's a good news. We have confirmation that overall survival is significantly improved, supporting enzalutamide plus radium. So I guess we now have a new standard of care, at least for patients who were treated with ADT alone or ADT docetaxel for hormone-sensitive disease. The RPs were rare at this time. Now, an open question is whether radium still improves outcomes in patients who have exhausted an AR pathway inhibitor. We just don't know. We don't have randomized data regarding that question, but we should get the answer soon. The RADIANT trial has completed its accrual and should read out anytime this year. We also have real-world data about radium, again supporting, I'm not going to go into all the details, but really supporting a quite nice safety profile. And it's true that we can actually use that treatment in the elderly, in frail patients, in sometimes hard to treat patients, honestly. Now, the question about the efficacy, of course, cannot be addressed by those real-world studies. Now, another radiopharm is obviously lutetium PSMA, which was developed on a one-by-one basis in Germany historically, and then in the first phase 2 study and then randomized phase 2 study by the Australian group before being looked at, in a broader space in a randomized phase 3 trial, which was a global trial called Vision. So those are the data. Both primary endpoints were significantly improved, radiographic progression-free survival, but also overall survival, with, I think, a quite meaningful benefit for these men who had exhausted both an AR pathway inhibitor and at least one taxane, and actually for 40% of them, 2 taxane, including cabazitaxel. So this became a standard of care in many places, including here in the US. A second trial tested lutetium PSMA earlier in the course of a disease. This is the PSMA-4 trial, and those patients were selected as not being candidate for immediate docetaxel while they had exhausted an AR pathway inhibitor, and they also had castration-resistant disease, obviously. So as you can see, not only the trial met its primary endpoint of radiographic progression-free survival, which was basically double, if you like to see medians, approximately 6 months in the control arm and approximately a year in the lutetium PSMA arm, so that's crystal clear better. But at the end of the day, what is more important to me is that we are also helping patients in terms of quality of life. The time to worsening in pain intensity, the time to FACT-P deterioration was both significantly improved in the lutetium PSMA arm. So in this trial, we decided, I think, to be kind to patients and to make really the trial a patient-friendly trial in a way that patients were randomized to receive either immediate lutetium PSMA or lutetium PSMA when they would progress in the control arm. So the crossover was enormous and actually fast, typically 6 to 8 months after randomization. And in this context, to me, it's really not a surprise that we don't see overall survival being improved, given that it was truly a comparison of lutetium PSMA today versus the same treatment in 6 or 8 months' time. Docetaxel is also obviously an important standard of care for patients with CRPC, and I think an important randomized phase 2 trial from Canada that just was released at ESMO last year reminds us the importance of taxane in this setting. And actually, this patient, as opposed to the one that I just showed you, the PSMA-4 trial, were selected to be candidate for chemo, while in the PSMA-4 trial, they were candidate for not receiving chemo, not immediately, because the pace of the disease was just different. PSMA-4, typically no visceral disease, slowly rising PSA, asymptomatic disease. So patients in whom you would not necessarily want to jump on docetaxel. While in the Canadian randomized trial, they were a candidate for the immediate docetaxel because they had bad disease. And in these men with bad disease, docetaxel is the way to go, not necessarily lutetium PSMA, and this is what the trial is suggesting, at least to me. The key question is whether we should use radioligand therapy with lutetium PSMA earlier in the course of a trial. We just saw the very first data from the PSMA addition trial testing this same treatment, but this time in castration-sensitive disease. The trial is positive, but I have to say that it's not as positive as I thought it might be. 28% reduction in the risk of radiographic progression-free survival, but it comes with no other benefit, at least by the current assessment, no quality of life, no overall survival, etc., etc. Why is that? It might actually be that using lutetium PSMA ideally should be done in patients with PSMA protein expression. It sounds to be obvious, but if you think about it, if you're starting your ADT and your RP for, say, 1 or 2 months, the expression of PSMA may go down dramatically, and then you're hitting a target which is partially gone with your lutetium PSMA. So maybe if we need to redo the trial, I would be in favor of hitting the cancer first with lutetium PSMA and then start perhaps the V2 hormonal agent. Again, it's easy to say now. We saw today new data regarding PSMA targeting, this time with alpha emitters, with the trillium, and there are also actinium and generally other actinium drugs being developed. They clearly work. And the question is whether eventually this treatment will be used post-lutetium PSMA or whether they may also replace lutetium PSMA with more efficacy, but very often also more toxicity to the salivary gland. In this particular treatment, which was presented by Fred Saad, the toxicity seems to be acceptable. Again, this is phase 1. We need more experience and look at the durability of the dry mouth. PARP inhibitors. This is, I guess, a big thing in prostate cancer, at least in selected patients. And this is my bias. I'll come back to that in a second. What do we have right now? Olaparib and rucaparib are both approved in this country as single-agent use in CRPC in patients with mostly BRCA alterations. Now, combinations, olaparib plus abiraterone, niraparib plus abiraterone, talazoparib plus enzalutamide are options in patients with castration-resistant disease, and the indications are somehow different between Europe and America. What are the data? So, PROPEL tested abiraterone with or without olaparib, And actually, the trial is positive in all comers by rPFS, but not by overall survival. But to be frank, the data is much more compelling for patients with BRCA alteration, where the magnitude of benefit is really big and probably worth it, the effort, the financial effort, but also the safety. I'll come back to that in a second. The hazard ratio is 0.3, basically, or even less than that. Magnitude tested the same hypothesis, but this time with niraparib tested on top of abiraterone. And again, we saw improvement in rPFS in the BRCA mutated population. TALAPRO-2 used a different backbone, RP, which is enzalutamide this time, and the trial assessed enzalutamide with or without talazoparib, a potent PARP inhibitor, looking at both rPFS and OS, and actually both were significantly improved in the trial in the all-comer population. But if you look at the data, again, patients with BRCA alterations and perhaps a few others derive most of the benefit, while for patients without those alterations, the benefit is much more modest and sometimes absent when it comes to overall survival. Today we saw some post-hoc analysis of this particular trial, just showing that so that you have access to if you want to look at. I'm not going to go into all the details, but it's getting more and more important, getting more information. And for example, we saw data regarding the rarer genes alterations. ATM doesn't seem to benefit, while PALB2 or CDK12, for example, alteration seem to derive benefit from PARP inhibition combined with AR pathway inhibitors. And this is why I think we really should test all the patients and test them more often. I know it's not necessarily covered everywhere by insurances or by social security system, depending on where you work, but it's getting more and more important clinically to test. And this is true for germline testing, not only for the patient, but for the family, obviously. And somatic testing is also important to help you make the decision. Those are data, to the left-hand side in the US and to the right-hand side in Europe about the frequency of testing. So you can see that testing made progresses in America from 2015 to COVID times, but right now it seems we are capping. So we need to again do a better job, and the same applies to many countries in Europe. As I said before, we are using the drugs earlier and earlier in the course of the disease. So, for example, we saw last year for the first time data from the Amplitude phase 3 trial looking at abiraterone plus or minus niraparib in patients with DDR alterations. And actually, the trial is clearly positive by rPFS, but also in terms of time to symptoms or symptom-free survival, which at the end of the day is clinically so important. Of course, too early to say for overall survival, but I think this is a clear signal that we will probably be using soon, pending approval, a PARP inhibitor in combination with an RP in the setting. We are just looking for or waiting for data from the TALAPRO-3 trial. Data should be analyzed anytime soon, and this time enzalutamide is combined with talazoparib, again in these patients with DDR alterations. So stay tuned. Hopefully we'll see the data this year. Why should we test? Again, because a PARP inhibitor doesn't come without toxicity, even not speaking about the financial issue. Anemia is seen very often, grade 3, grade 4, depending on the drug, depending on the combination, say 20% up to 40%. And grade 3 and 4 means transfusion, not only fatigue, asthenia, anorexia, all these things. That's clinically very important to the patient, to the health systems. So again, I'd like really to choose patients who are most likely to benefit, not necessarily treat my all-comer patients. The GI side effects are mostly easy to handle, I would say, at least in my practice. This was reassuring, and this applies to both the diarrhea and the nausea. Rarely, but importantly, secondary leukemias or AML, pneumonitis, thrombotic events, including pulmonary embolism, can be seen in excess with these agents. So again, those are important findings clinically to support selecting patients who are most likely to benefit. So as you just heard, it's getting complex to treat patients with mCRPC, but really for good reasons, as compared to what we had 10 or 15 years ago. So we do need to do homework, we need to test, we need to learn what the data are, what the side effects are, to be able to provide the best treatment to all the patients. Again, I'm not going to go into all these details. This is mostly to help you if you need that. Let's focus on one patient for the coming minutes. So this is Joel, 65-year, similar to the patients that was presented by Mav. This is patients with de novo and extensive metastatic hormone-sensitive disease, who's quite fit and a little younger, is receiving a triplet with abiraterone, became asymptomatic, and it took 4 years for him to progress. And actually, I chose 4 years just because this is exactly what we saw in PEACE-1, for example, as a median time to progression, as opposed to just 1 year, a couple years ago when we were using ADT alone in these men. So now he has CRPC, is progressing with new bone lesions, PSA is rising, also ALK-phos are up, and let's say that the NGS is down with no genomic alterations that we can use as targets. So the question is, what's next? And you saw that we have several options. We can go for second taxane, cabazitaxel is supported by CARD. We can go for lutetium PSMA. We may think about enzalutamide, but with probably minor efficacy and no OS benefit. But we just saw the PEACE-3 data today, and a key question is whether the PEACE-3 data applies to this gentleman who has received abiraterone and docetaxel for hormone-sensitive disease, which was not the case when PEACE-3 was designed. So we don't really know. But maybe let me ask my colleague, would you perhaps consider enzalutamide and radium as reasonable options in this gentleman, understanding that we don't have direct evidence to support that?
Yeah, I'll answer that. But before I do, I'd say the other option you may not have mentioned is retreating with docetaxel, right? For 3.5 or 4 years off treatment. If he's going to get chemotherapy, I would probably start with docetaxel before going directly to cabazitaxel in a durable responder like this. To your question, of course, the PEACE data don't tell us whether the enza radium apply, but I think it's a reasonable consideration, particularly in someone who's a durable responder. I have little or no enthusiasm for the ARPI switch alone. I do find the data compelling. I hope we eventually get there with phase 3 data to know whether that applies, but I think it's a reasonable consideration here.
Yeah, I mean, I agree with Matthew. I mean, I think to do a doublet, if you will, that includes an RP, we don't know if that has any benefit over just doing radium alone or not. He has bone predominant disease. I'm not sure if that means there's some nodes, there's some other stuff. Pure bone. So it puts radium on the table, because otherwise, some nodes, some visceral, not so much. I mean, I realize I'm the surgeon in the room, but I like chemotherapy, and we have randomized trial that he would have qualified chemo versus lutetium. And you didn't tell us what his PSMA imaging was, but let's assume it's positive, as most of these patients are. We have randomized phase 2 data that chemo has a survival advantage. So given the unknownness of the PEACE-3 data, and assuming he is willing to undergo chemo. That's one of the big things. As you said, younger, 65, that's probably the way I would push them.
All right, thank you. Let's switch about, a bit the case. Let's say that he has germline BRCA mutations. Would you go for PARP? Would you do PARP plus, say, enzalutamide, given he was on abiraterone yesterday?
I would not. I don't think we have the data there. Like I would, we look so hard to find these. When you find them, given the strength of the data with either monotherapy or combination in ARPI naive patients, I really do prioritize treating with the PARP inhibitor. So in my practice, I would treat a patient like this with a PARP inhibitor monotherapy.
I would, as similar, but I would do the combination. In that he's failed Abby. We do see Enza has a little bit of activity post Abby, and you have a great PARP with that. So I'd probably do the combination.
So you see two experts, two opinions, and hard to say.
We agree on PARP. It's just
of course, and it's unknown. It's really where it's hard to say. And I mean, on the fence, same. Let's say that this is CDK12 alteration.
Well, we know they do very badly. Unfortunately, it's humbling how poorly these patients do, both like from the published data as well as my own experience with biallelic loss of CDK12.
So would that be a good reason to go for taxane first? Or
unfortunately, they do poorly with pretty much all therapy. So, and there's some data about OI in these patients, but checkpoint inhibitors, the data it's very weak supporting it, CDK12 when it's been looked at. So there's not a lot, but I wouldn't prioritize a PARP inhibitor here. I'd probably treat him with carbocabazitaxel.
All right. I think we need to move on for sake of time. Again, this may help you guys, patients and your patients, obviously, so feel free, of course, to have a look. Thank you very much for joining us. And with us, we thank you very much for your attention tonight. Thank you.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, ZERO Prostate Cancer. This activity is supported by educational grants from Astellas and Pfizer Incorporated and Bayer HealthCare Pharmaceuticals Incorporated. To access all materials for this activity, visit peerview.com/TRG860.